Good morning, all. Good morning, sir. I thank the organizers for the opportunity. I'll be speaking on alectinib, a niche trial, a niche abstract. This reminds me of imatinib because as the survivor for ALK patients is increasing, we are now dissecting each and every side effect. So this abstract was presented by Melinda et al. At European Lung Cancer Congress this year. It is clinical implications of cardiotoxicity and PK of alectinib in ALK-positive patients. So we know that ALK-positive patients have long-term survival with alectinib. The known cardiotoxicity of alectinib is edema, bradycardia. This can lead to dose reductions, which can have a relation to the long-term exposure response and the clinical profile, that is the response of the medicine. The trial is a simple trial. It's a 53 patients data, which was taken from Netherlands in June 20 to September 21. There were two cohorts. One was the prospective cohort and one was a cross-sectional cohort, that is patients already on the drug. The new cohort, that is the prospective patients, they underwent cardiac evaluation at 3 months, at 6 months and at 1 year. Those patients were already on alectinib. They underwent more than 6-month evaluation. Data was sorted out as grade 3 adverse events and also PK levels were taken. So total of 53 patients were evaluated. The prospective cohort had 19 patients. Data of 16 patients was available for PK studies. The cross-sectional cohort had 34 patients. Data of 31 patients was available for PK studies. So this is the overview of the abstract. These are the results. So we're looking at EF. The thing that worries us most is the EF. The EF was maintained, was normal in all the patients who underwent the on-treatment cardiac workup, including the both cohorts. But the thing that was surprising was the heart rate significantly decreased during treatment with alectinib. You can see that the median heart rate at baseline was between 70 and 80. At 1 year, it has dropped down between 60 and 70. 7 patients had alectinib-related edema. This is only 13%. 22 patients, that is around 40 patients, 40% of patients developed alectinib-related bradycardia. This had 16 grade 1, 5 grade 2, and 1 grade 3 patient needing a pacemaker replacement. 9 patients required at least 1 dose reduction due to this. This resulted in the subtherapeutic trough value. The level therapeutic value is 435. So 5 patients had a value that was less than that. So looking at the PK levels, the target was 43, more than 435 nanogram per ml. So those who had a higher level, you look at the severe toxicity, they had a higher level of alectinib, 735 versus 533. That was the optimum level in the patients who did not have any cardiotoxicity. So in conclusions, we look at EF, we look at edema, we look at bradycardia. So EF was maintained in all the patients. Edema was seen in only 13% of patients. The effect that is seen in alectinib more, we concentrate more on side effects like liver toxicity, but bradycardia was more often seen in 40% of patients, and it was an important reason for dose modification, resulting in subtherapeutic exposure in 5% of patients. In general, severe toxicity have a relatively high exposure to alectinib, well above the therapeutic threshold. So the implications for the clinical practice is to monitor the pulse, not just the EF. And EF we can monitor at maybe 6 months, but pulse and ECG at every 3-month interval for all my patients on alectinib. Thank you.